any function where there's a human interaction with a screen,
Yep.
eventually AI is going to deal with you. We launched ambient listening first in AI because we saw the potential there. If you've talked to physicians, burnout rates down 70% after launching that, and the experience is wonderful. We are like a walled castle. We've built these hospitals and clinics and rooted out of those castles anything that was not covered by insurance becomes really difficult to access. And where we really need to move is to break down those walls and move to like a vibrant city. And I think that's where we are in healthcare today. We've launched a number of digital inventions and products, but they were pre-AI. So I think we've got to circle back to some of those and say, how do we really supercharge them and put the rocket fuel of AI into them?
All right. Well, it is a pleasure to be here with Pete McCanna, who is currently the CEO of Baylor Scott White. Baylor Scott White is one of the largest not-for-profit hospital systems, certainly in Texas, if not the entire country. I think you guys are like a top 20 hospital system, perhaps even in the world, I would guess. But and you were previously the president there, but have had a long-ranging career in healthcare that we'll talk a lot about here that I think gives you a very unique vantage point on both where healthcare has been for the past several decades, where it is today, and where it will head in the future. So thank you so much for being with us.
It's a pleasure to be here.
Excellent. Let's actually start with your story, Pete. Walk us through your, 40-plus year history of being a healthcare leader in various health systems, a lot of different environments too. Yeah. And maybe do like a little bit of a highlight reel of what were kind of the themes of your career path as you transition between the various organizations that you've been at.
Yeah, no, I've been fortunate. It wasn't planned this way, but it's almost like in these 5-year increments, different challenges. I started out in consulting in Washington, D.C. For a firm called Lewin at the time. And great exposure, great learning. Then I worked as a budget director for the safety net system in Denver. Fabulous experience because everything was broken administratively. So you had to learn everything.
Could only go up from there.
Right. And then became CFO at a young age at University of Colorado. So started out in academic medicine in the C-suite, moved on to a large integrated community system called Presbyterian in New Mexico, and then spent 15 years at Northwestern, first as the CFO, then Chief Administrative Officer, then Chief Operating Officer, and came to Baylor Scott White as president, and about 4 years ago became CEO. So I've been fortunate because I've been in both the academic environment and the community health system environment, and in a multitude of roles. So I feel like I understand how the machine works. And now as CEO, it's a great opportunity to say, okay, let's stake out a vision and take that machine and re-engineer that machine to get the outcomes that we want.
Yeah. No, and you mentioned the academic versus community-based health system environments. I think a lot of folks know sort of conceptually the difference between the two, but what would you say are the biggest differences between, from an operating perspective and leadership perspective between those two environments?
Yeah, I think one of the biggest differences is, who are your substantive stakeholders, the real stakeholders you're serving. In an academic environment, essentially the power structure and the key stakeholders that are the keepers and stewards of the mission really are the chairs and the chiefs of the departments and the divisions. And the challenge there is getting clarity. Is there a unifying vision for the academic center? And then getting the incentives right with those chairs and chiefs. And if you get that right, it's incredibly powerful. If you don't get that right, it's very frustrating because you've got multitude of objectives going on and trying to serve that. When I was at Northwestern, I really felt that we got to the point where we got it right because we really said with the chairs and the chiefs, we are going to be a top 10 health system, academic health system. We're going to get to honor roll. Chicago deserves an honor roll. And then we broke it down and said we're going to have to double our NIH research, which is a big goal. And financially, we aligned the incentives where the chairs were incentived for profitable growth. And prior to aligning the incentives, they essentially fought every expansion initiative because it took focus away from the mothership. And once we got the incentives right, I actually had to slow them down.
Interesting.
Yeah. So I think it can be really powerful. But the object of their work is really the advancement of knowledge.
Right.
and research. It's really research. I mean, education's in the environment too important, but the really big goal is really advance knowledge, and as we said at Northwestern, really reduce human suffering by that. And that's a powerful why in that environment. In a community environment, you're really serving a community health system. You're serving the patient at the core and the broader community, and the objective isn't high acuity, cutting edge research. The objective is how do we wrap ourselves around you in your health journey and provide you an array of services so you and your family can manage your health, and much more focus at the provider level of providing great care from primary care to secondary to tertiary, and it's a different set of stakeholders.
It seems much more political in the academic environment, the way you're describing it.
Highly political.
Yes.
Yeah,
Okay.
It takes some skill. I think the community environment for what we're setting out to do at Baylor Scott White is a community health system is much better positioned in its orientation and mission to really be customer-centric, because it does value that 24/7 array of services that we need to provide to you.
Right.
And so that's been a great platform to do that.
Yeah, amazing. And we'll come back to that because you've clearly done an amazing job with the platform that you have. But you've also, and you mentioned it a little bit at the beginning, in your background that, you sort of inherited a lot of broken systems. And, you've been very vocal about the fact that despite the fact that you've been a leader in this industry and sort of part and parcel with, everything that's happened in the industry, that the industry is fundamentally broken, and it's, rare to hear people on the inside sort of admit that. And you've also referred in our last conversation about, hospital systems sort of being these walled gardens.
Yeah.
Explain to us what you mean by that.
Well, I think, first on the concept of the realization of a broken system. When I first became CEO, intellectually, I understood that we needed to move to a new model. But it was an intellectual conclusion. And for me, where it really changed for me was when, in the last 2 years of my dad's life, helping him navigate the healthcare system. And here I was, a CEO of a major health system. It was a different city, but I should know how to do this. And it was impossible for me. And I saw the pain and suffering of it. I saw the cost implications of it. I saw all those difficult things. And as I've shared, my dad would make this list. He was very analytical. He'd make this list of the things that needed to change. And I reached a conclusion, my whole career, I've been complicit in building this broken system. I made the assumption that if I can build and make these organizations strong because they provide health care, I'm doing something really good. And I think there's some truth to that. But at the end of the day, I felt like, I'm down the wrong path. We're down the wrong path. We have got to, what's the object of what we're doing? It's not to make the organization strong. The pivot for me was the object is the customer. And when I say customer, a lot of people struggle with that within legacy systems. What I mean is it's an elevated status that you're always a customer to us. You're sometimes a patient. And that means I worry about you 24/7, and I want to know what I need to deliver to you. That's a whole different mindset than the 30 to 40 years of the calcified systems. And that leads to the metaphor that you mentioned is we are like a walled castle or walled garden. We've built these hospitals and clinics and rooted out of those castles anything that was not covered by insurance, that was somehow regulation rooted out. A classic example is behavioral health. Anything occurring in the home, hey, not covered, drive it out. So it becomes really difficult to access and is very focused on safety and security, and is very episodic, and it responds when there's a crisis. And where we really need to move is to break down those walls and move to, the analogy would be like a vibrant city where it's open, traffic flows through it, it's innovating, and access is open. And I think that's where we are in healthcare today. And from my standpoint, the only way to do that is really to partner the legacy health systems, the walled castles, with the innovators. I think it only happens through that combination. I don't think either segment can do it totally on their own and really transform it into the type of health system that we would envision really serves our needs.
So let's use this to pivot
Yeah.
into, let's talk about like, what is the business of being a hospital system?
Yeah.
So if you think about the average health system in America today, talk us through, how do you make money?
Yeah.
What are the drivers of revenue? What are the
Yeah.
drivers of margin? What are the key operating levers of the business that a CEO in that seat would think about?
Yeah, and I'm going to qualify it. I'm going to describe the traditional model.
Sure. Yep.
That's not where we're going as Baylor Scott White at this point, but we're sort of in between. The traditional model is first, let's break it down. How do you make money? Let's start on the revenue line. On the revenue line, it's a few vectors, I guess I would say. Vector number one is I've got these hospitals and I've got these clinics that I've invested millions, hundreds of millions of dollars in. It's a supply-driven model.
Mm-hmm.
I've got the supply of assets. What are the array of tactics to fill the supply? It's as simple as that. And if you take any operator in healthcare, they could tell you what those dozen tactics are. Service mix. So what's the most profitable service mix? Payer mix. There is a minimum commercial volume that a system really needs to have for it to be economically viable, because all the government business loses money, so you've got to have an offset to that. And it's payer negotiations would be another example. So there's sort of this micro optimization of aspects of the revenue line to optimize it. Unfortunately, by doing that, you are rooting out very important aspects of the health system if your objective was actually to keep people healthy, unfortunately. But we're looking at 30, 40 years of that evolution. On the cost side, half of the cost structure is labor. So those organizations that have very sophisticated staffing models that are matched to volume, a good example would be HCA. And some of the not-for-profit systems do it well. I think we do it well. Labor management becomes crucially important, particularly on the clinical side. And if you have a really, really disciplined operating model, you can do that. And then on the administrative cost side, increasingly are a number of things you can do there to do cost. And then I would say last but not least, really high-performing health systems financially are really good capital allocators. So, health system our size may be allocating $1 billion of capital a year. And making those decisions on the margin of what works and what doesn't work. I would add one other thing, and at Baylor Scott White, it's a difficult thing for a not-for-profit system. It's related to capital allocation, but it's what's done in other businesses all the time, but hard for not-for-profits to do, and that is to periodically evaluate its portfolio of assets, and at sometimes you're going to need to walk away and close some assets. That their continued trying to make them work are actually hurting your mission because they're pulling so much resource into it, and you're concluding you're not doing a good job.
Is that always a purely financial decision? Or
no,
what
it's
else
not
goes
always.
into that?
Honestly, it comes down to, can we be excellent at this? And if you can't be excellent at it. I would conclude, though, the traditional healthcare system model is a zero-sum game in the markets that they're in. So the markets I've been in, it's always take market share from the other guy, take the best doctors from the other guy, get the best technology from the other guy, and fundamentally you're not creating incremental value for the customer, because there's very few health systems really are builders and creating new innovative approaches. And that's why, again, what we're doing at Baylor Scott White is to say, okay, we're increasingly saying, is this allocation of capital creating value for the customer? In the old model, we might go forward as creating a good return, but maybe a zero-sum return. And the new model is, no, we're moving this forward in this context, create value for the customer and have it be a good financial decision, and then it's a go.
So talk to us about that, because you just described a lot of different paradoxes there.
Yeah.
Where you mentioned at the beginning it's a supply-driven market, which
Right.
100% is, I think, the case that any consumer experiencing healthcare would agree with that.
Right.
The example that I always use is when you look at a hospital system's website, the way that you present your services, or most health systems present services, is by service line, by department. And yet, I, as a consumer, if I've got pain in my chest? How do I know if I have to go to the
Right.
cardiology department or the pulmonology department or the neurology department? It's entirely sort of architected in a way that reflects the org structure, so to speak.
Right.
And then yet you just said, every investment decision that you're making on a go-forward basis has to be accretive, or has to crack the status quo in some way, shape, or form. So talk to us about what's an example of that? What's an example of a product or a service that would not work in this kind of status quo model, this kind of supply-driven model, but you're willing to make a bet on? And then also, help us understand what KPIs are you looking for when you're measuring whether or not to sustain that over time? Because I presume that this is not you're going to see an ROI in 6 month type deal, that you may have to have a longer time horizon. So how do you justify that in the course of your day-to-day operations?
Right. So a couple examples. One is it starts with customer research and analysis. So what are our customer pain points? What are the gaps in the system that aren't satisfying customer demand? So that's what I mean by demand driven. Let's understand the demand of our customer base and some conclusions that we drew from that. And I'll give you actually several examples. Number one is, the obvious example, behavioral health. I think system-wide, we're a $17 billion system serving 12 million encounters a year. I think we had 10 psychiatrists on staff, no access to behavioral health really for a new patient. So we looked for a model that we weren't naive to think we're going to solve every behavioral health problem, but can we get started somewhere? And we found a partner in GP Julie Health, which is a hybrid platform, and with physical clinics, with a psychiatrist, clinical psychologists, licensed clinical social workers, that was financially sustainable, and invested in that to fill that gap. That would be an example of one example. Another, which sort of breaks the service line model, is we looked at what common conditions do people have that aren't adequately treated by a health system. Great example is headache care. So in a typical health system, we say, well, the neurology service line, what does that mean? And people with chronic headaches, can we create a platform, a service offering that focuses on that particular problem and gives them immediate access to relief? And the model that we have is, once you're through the evaluation, you qualify through putting your symptoms in, immediately you're connected with a headache specialist, not a general neurologist who doesn't even want to see you, wants to see someone else. Headache specialist, and getting the prescription or the treatment you want right away. And the list goes on, and we keep stacking on that with very targeted solutions to often chronic problems that people have. So it's focused around the customer problem. It's not focused around what our supply of services are, or specialties.
In that example, did you find that the reimbursement system was conducive to that product, or did you have to do some ninja moves on that side to make it work?
It's a good question. So one of the tensions in our strategy is some of the things that we're doing may or may not be reimbursed on a fee-for-service basis, okay? But because we have this large ecosystem, and you asked the question about KPIs, what we're looking for is ways to enhance customer loyalty, ways to enhance customer retention, and ways to attract new customers to Baylor Scott White. So the bet here is, can we provide a reasonably economic, sustainable, individual solution? But the bigger bet is how all these things knit together into what fancy name mega product, we don't have a name for it, fit together in the overall mega product of Baylor Scott White. And if we can knit that all together, convenience, we're proactive for your care, we're providing you a wide array of services that meet your problems, that you're going to be loyal to us and you're going to come to us. And particularly for those patients and families that have choice, they're going to come to us and stay with us. And so we monitor new patient acquisition, we monitor customer retention, we monitor customer loyalty, and also we're monitoring our ability to match supply and demand, which increasingly becomes important in this model, that we're willing to reconfigure the delivery system to match that demand. And thus far, it's been really good. Profitability overall has been good. I don't think I can draw a complete through line to each one, to those outcomes, But I think we've created a dynamic model that if something that isn't working, we'll replace it with something else.
Yep.
But to execute on that model, we're going to need outside expertise as well
Yep.
to really make that work.
I mean, in some ways, the KPIs that you're describing are like that of any consumer business.
Yes.
And so
I mean,
it's
surprise,
refreshing
surprise. Right, yeah.
to know
Yeah.
that we're finally, using sort
Yeah.
of like rational business frameworks to
Exactly.
understand our customer base. You also mentioned earlier that you don't want to be investing in things unless you can justify that you will be excellent at that. And that's, I think, for the scale of organization that you run, it's very hard to imagine that you can necessarily be excellent at the 100 different things that you do. And us in the startup world, we always tell our founders, like, focus, focus, focus. And the only advantage you have is to be excellent at one thing and then kind of earn the right to do other things over time. But
Right.
how do you reconcile that? How do you justify, trying to be excellent at so many different things under one roof?
Well, I think, this sounds like a rationalization, but it's really not. In some of the things we're doing, they're not being done elsewhere. So simply being in the space,
Being the only game in town.
being the only
Yeah,
game in
okay.
town is, hey, we're filling a gap here.
Yep,
That
that's fair.
the alternative is they have nothing. So if someone has chronic headaches, there's not another service offering in town that really addresses that. So it still gives us the opportunity to get better, better, and learn from it. But I think the first hurdle is, are we addressing a unique gap in the marketplace that's differentiating us and delivering something to the customer base that they need?
Yeah, no, that's totally fair.
Yeah.
Related to that, you mentioned also like locality of healthcare. Everyone always says healthcare is local. That's kind of the trope. And yet we now are seeing, the advent of pretty impressive national scale healthcare brands for the first
Yep.
time that are very consumer centric, whether it be the Hims and the Hers of the world. And they might be starting with, what we would consider more ancillary services, but increasingly getting more into sort of core care delivery. You've got companies like Hinge and Omada that both went public earlier this year that are similarly, national virtual first brands that serve customers in this sort of longitudinal way. How do you think about those entrants, and are they today making an impact at all to how you think about your services mix and how you're designing your competitive strategy, things like that? Or are we still several years away from, sort of local institutions like yours really caring about, some of those new emerging players?
Yeah, I mean, well, I really look at those new emerging players, and I want to learn from how they make direct to consumer attractive. So like Hims and Hers, I think it's really brilliant, sort of their marketing approaches to bring people in.
Yep.
And if you get under the hood of those, they're marketing organizations, I think. I think they are, and then they're attaching things to that. So I think that's fascinating. I think health systems have been local, and they've been local because up until this point, the delivery of healthcare has all been physical. It's the physical hospital and the physicians attached to that hospital and practicing there. It just reflects the local environment. I think with the digital platforms, it opens the door to scalability outside of geography. In our circumstance, Longitude is a collaboration company that we've created, and it puts together 4 or 5 health systems. We'll probably grow to about 10, and really ask the question, are there businesses, direct to customer, or capabilities that health systems need that are going to be more effective, more efficient, and we can build equity together at scale? So really ask that question, and the answer to that is yes, there are. And our first venture is specialty pharmacy. So the capabilities of a really high-performing specialty pharmacy service business, you need data, you need a large service base, you need expertise around 340B and all those types of things. It makes sense, and we'll be looking for those things. So that's one example. And then the other example is in our ecosystem, what we're doing is some of these solutions that I just mentioned, can they be commercialized? Can we pull them out and find a distribution channel outside of our geography? An example of that is Levanto, which is a portfolio of services. And what's interesting there is the distribution channel is the employer. So it's sort of most of what we're doing inside our ecosystem is B2C, and Levanto is B2B to C, and realizing that some things only will be offered to our customers if they're offered through their employer. And Levanto is a pathway to do that.
And that was an example of taking a bundle of services that were developed in-house at
Yes.
Baylor Scott White and then packaging
Yeah.
them into a commercializable solution.
Yeah,
for
so
the
muscle and
outside world.
joint care, headache care, postpartum care. I'm missing a couple of others, navigation. and putting them into one wrapper. So if you're an employer today, you've got all these vendors, 100-point solutions, and what works. We say is no. Here are the high volume ones. These are the ones that are really important from our research.
Almost like a formulary of sorts.
Yeah, and you can work with us. And oh, by the way, you have the confidence. It's been tested in this environment that has 3 million connected customers. And we've done the A/B testing, and sometimes we've done the deeper research through our research institute, so we can show you it affects cost, good clinical outcomes, you can trust it, and it's got Baylor Scott White behind it. So that's what we're setting out to do.
So you mentioned earlier your top line number, I think just over $17 billion in revenue for the health system. And your operating income last year was, you had a 10% operating margin, which is like unheard of in our industry. And it's I feel like these days to even be in the black is sort of an aspiration for most systems, especially coming out of the difficult times of of COVID and so many of the reimbursement pressures that the entire industry is seeing these days. What's your secret? Is it the things that you're talking about now? Is it these new programs that are already manifesting like at the P&L level, or what are the other drivers that are enabling you to be so successful financially?
Well, I think in any big company, any big business like this, you have to have a disciplined operating model, and Baylor Scott White over the years, and the executives on the team, a fabulous team that we have, has a very disciplined operating model. So cost management is crucially important. Labor productivity continues to be important. How we allocate our capital continues to be really important. So there are elements that don't necessarily have to do with the customer strategy, but are core foundational excellence that you just have to do.
Just the fundamentals.
Fundamentals, and they become crucially important. On top of that, if you can execute well fundamentally, but then also insert the new solutions that are customer-centric, now you're getting the new customers, you're getting the volume, getting that tailwind as well. And when the both come together, when the top line and when the top line revenue and your expense line is disciplined and growing, and the expense line is being very disciplined in terms of management, it's what happens. And I think we're fortunate. I feel fortunate that we continue to. We look at the bottom line as we're unapologetic about the bottom line, because that's our source of capital. That's how we're going to transform Baylor Scott White. So if we're doing that, we're taking every penny of that and plowing it back into that transformation. So we think it's really important. We just think it accelerates our ability to move from, like I said, a supply-driven system to a demand-driven system.
Where have you applied AI internally? And is some of that already showing up on your P&L as well?
Not showing up on the P&L yet. And I think the challenge for us on AI is we've launched a number of digital and technologically fueled inventions and products, but they were pre-AI. So I think we've got to circle back to some of those and say, how do we really supercharge them and put the rocket fuel of AI into them and change them? So we're going through that. That's on the product side. On the operational side, we've launched a number of things on AI, but we're in the early stages. How do you apply AI in terms of, example would be our transfer center. We're a large health system. It's complicated. Where do you put people in beds? How do you make that work? Another place where the AI is in our navigation system. So we have a product called Help Me Decide, where you go through a symptom presentation online, but how do you inject AI into that so that you're triaging people to the right place and doing that in the right way? I think some of the AI in imaging is super powerful. I mean, it's so powerful that it would be malpractice not to deploy it. It's that important. So
you didn't say revenue cycle. That's like kind of the area that everyone's talking about these days, where providers are ahead of payers and the rest of the market.
Our
in
rev
terms of
cycle's
adoption.
so good. We don't even need AI. No, AI is permeating all the administrative functions, and in rev cycle you'll see it. I mean, there's a number of tools, and I just don't see. I think they're important. I think from our standpoint, they're going to be certain deployment of AI that every health system will deploy, which is fine. We may not be on the cutting edge, but we'll get there in the way that we manage the business. I think the thing for us is, what are the applications of AI that if we injected into our service offerings and what we do, that would differentiate us and really put us out ahead.
let's talk a little bit maybe about how you approach the labor side of the equation, which you've mentioned a number of times, specifically at Baylor Scott White. Maybe describe, the composition of labor in healthcare today, as we've all read about in kind of mainstream headlines, a ton of emphasis on just the overhead, right? We have a lot of administrative overhead. Yeah. I think there's ratios everywhere between, for every one clinician, there's at least 10 administrators, and that number's only ballooned, over the years or the decades since. But is that, where do you see the most leverage in terms of the opportunity to streamline costs and, be more productive, et cetera, based on today's labor force? And what would you project the labor force, where will it look different in, let's call it 5 years' time, based on all these dynamics?
Yeah, I think there is a very strong possibility. Let's just say that the administrative overhead in the health system is 15%, for sake of argument. Now, there's embedded administrative, but if you look at corporate services, I think it in half, that cost structure. I think there's the opportunity of that. Ultimately, AI, any function where there's a human interaction with a screen, eventually AI is going to deal with that. And increasingly, human functions where there's a telephonic interaction, call centers as an example, AI is going to play a big role in that with agents. So I think that's going to roll out. I think health systems are going to need to deal with the labor dislocation because you're looking at, a system our size. We have 57,000 employees. On the administrative side, it's at least 6,000 people. So you're looking at major labor dislocation. So how do we get out in front of it? How do we grow into that? Or how do we do retraining in some areas, particularly into the clinical side? And that's where you'll see a slower adoption of those tools because I think it'll be hard for some systems to get their head around that. But I think there's huge opportunity in the administrative side. And from our vision and our strategy standpoint, holding on to that creates no value, in fact, negative value. If we're all about the customer, we're going to get more efficient there and make those services even better through automation and then drive that freed up capital into creating great products and services for our customers.
What are you actually hearing from your frontline clinician staff about the AI era? Are there pockets where they are embracing it? We hear a lot about AI scribes and other tools like that getting mass adoption on the front lines, but perhaps other areas where it's a little scarier. What's kind of your sentiment analysis these days for your staff?
Yeah, intentionally we launched ambient listening first in AI because we saw the potential there, and we wanted to really create a very positive cultural positioning to AI, and ambient listening's been a home run technologically. And if you've talked to physicians, many of them, we've measured burnout rates down 70% after launching that, and the experience. If you've ever, I don't know if you've gone through the experience. The experience is wonderful. Like you sit down and you have a conversation with your physician, and likewise, the physicians have said the same. It's brought the joy back into medicine. I can actually talk to my patient, understand, make eye contact, have a conversation, and then I don't have to worry about generating the note and the like. So, and many have said it's the first time application of technology in their environment actually helped them,
been positive.
Which is really a sad statement on the deploying of technology in healthcare environments. So that's been very, very successful. I suspect the imaging deployments will be as well. I mean, the fact that you can have AI, the old model would be you've got a radiologist reading images in a queue coming out of different parts of the system, particularly the emergency department, and then going through one by one in the queue where AI can read them all immediately and immediately pop up on his or her screen and say, there's a potential critical finding, go there first. Those literally are saving lives because that delay, and those are super powerful. So you're going to see AI, in the product area for innovation. You're going to see it in the core delivery of clinical care like we just talked about, and then you're going to see it in the administrative environment driving cost out. Last but not least, you're going to see it in just the personal assistant area, which I think will grow on the clinical side.
Like co-pilots, you mean?
Yeah.
And for consumers, hopefully,
Yeah.
as well. Yeah, on the consumer side, I'm curious too. I mean, we've been kind of touching gently at the edges of the, what's happening at the provider-payer interface, whether it be on the just the general mix of the population. There's obviously a lot of turbulence right now around different lines of business and what coverage is going to look like in the coming years. There's also a tremendous amount of, or at least we in our world see a huge trend towards more cash pay behaviors, where there's now more of availability of services that are being provided at disruptive cost level or pricing levels, with far more convenience, et cetera, as we talked about some of the examples there. How do you think about the consumer sort of dimension of the payment rails? Like, are you guys actually seeing uptake in more direct-to-consumer, cash pay services?
Yeah.
Is that part of your strategy to lean into that? How do you see that playing out over the next few years?
Today, very little, but we recognize as we launch some of these products, we're going to have to go there because some of the pain points or some of the innovations that help you. The problem with the U.S. healthcare system is we're really good inside the walls of the hospital and the clinic, and then you're on your own.
Yep.
And as we begin to fill that space, particularly in the home, we've launched what we call Care Companions, which basically, if you're discharged, it gives you everything you need between appointments and really supports you for different clinical conditions. There are going to be certain aspects of that we're going to need to see cash pay for, and that customers will pay for it. So I think you'll see a mix over time. If we're completely shackled to coverage in what we're doing, I don't think we're going to have the innovation, because coverage, at least in the United States, for the most part, doesn't like access. And our whole model is predicated on access. It's saying if we actually, paradoxically to that conclusion, if we open up access and give you more choice to consume healthcare services, to manage your health and engage you in that, actually lifetime costs go down. But the coverage system isn't designed that way. Coverage system is, I have a member, I've got them for a year, I got to tamp down unnecessary utilization. So it's a different set of incentives.
Talk about zero-sum game.
Yeah.
Have there been any initiatives or efforts on your part or from BSW to partner with payers in some unique way or different way than the status quo, given kind of the race to the bottom dynamics of the current ecosystem?
Not yet, but we're open to it. I'd love to see that. I mean, one would be on the payment experience for our customers. I mean, with AI and the deployment of AI, rather than a arms race between payers and providers just hitting up against each other, let's find a product that does both, and that we both benefit from and our customers benefit from. I think there's some intriguing opportunities there. And I think as we get deeper into our model, I think payers will become more interested. I think our ability to navigate and close that loop, scheduling. So I think some of the navigation tools out there, they're really powerful, but unless you get inside the walled castle, and we got the keys to open up the schedules, it's going to stop somewhere. But I think payers should be interested in partnering with us, and I think we'll see that, where their members, our customers and patients, can seamlessly really schedule their care all the way through and close that loop and navigate the healthcare system. You'll see some partnerships there, I think.
Yeah, you're touching on an issue that's near and dear to my heart. I was previously the founder of Kairos, which was aiming to sort of create better access and open schedules, and we always hit the sort of steel wall of the cultural change. It was never a technological issue. It was always the cultural issue of the willingness to open up schedules and enable, whether it be a consumer or a third-party provider, to refer in. Have you guys made progress on that? Is there light at the end of that tunnel in terms of
I think there is.
More open access?
And I think there is. And again, this really reinforces that the partnership needs to be there. So the big thing on schedules is, for many of your specialty practices, especially private practice, they're like, I'm not going to give you access to my schedule. I'm fine. But I think to the point where if we can create a platform that customers are using religiously, then it breaks down those walls. And the key is how many demands of the customer in terms of a schedule can you satisfy? And that takes a lot of legwork. It takes trust. It takes data to show the providers, listen, open it up. It's good for you. It's good for your patients, and move to that level. So that becomes essential. So some of these things, they're technologically enabled, but you got to do some of the really down and in work to kind of replumb the system to make it work.
Yeah. You've shared a number of examples of partnering with outside, vendors and parties to execute against your strategies, which I think, having been a Baylor Scott was a customer of mine in my past life, and you guys were excellent to work with. And always at the
good to
tip of
hear
the spear.
that.
and particularly progressive, I think, about the patient experience element of things. But you probably get pitched, 100 things a week. What are the characteristics of the things that do end up successfully catching your attention, versus not?
Yeah.
And what advice do you give to people who are trying to approach you to, get their value proposition on your radar?
It's a good question. I'd say a couple of things. Number one, have they rigorously understood a customer problem? And is the design of what they're bringing forward and the product they're bringing forward really focused and shown to be able to solve that problem? So their level of customer centricity and the sophistication on understanding what the job to be done for the customer is. That's number one. Number two is something I came to a little bit later, and that is if you really look at a great business, they've got the what right, so they're going to solve this problem. But when I see founders with their passion around doing that, where it's more than, so if a founder or someone from a company comes to us and they talk about, well, the TAM is this, and they're talking about how great the business fundamentals are, that's interesting to me. But if you get someone who is unbelievably persistent about, I'm not going to stop until I solve this problem, that's very compelling for us, because that's very much aligned with, I think, how I am in what we're doing and what my team is like. We got the what, but the purpose behind it and the conviction behind it becomes crucially important. And that's sort of the intangible that I'm looking for. When we
we see the same thing in my line of work too. It's also because it's so hard to build a company from scratch. And so if you're not doing it for the right reasons, then it's just not worth it. So you want to be part of it
because you can,
for that reason.
The way I look at it in terms of our vision, our strategy, I sort of say to people, I can tell you we will get it done. I can't tell you exactly when. We'll have a plan for when, but we're going to run into problems along the way. But our deep conviction, it's both head and heart here, and our deep conviction about truly transforming healthcare for the customer, we're going to get there. We will get there. And that persistence is what a good business needs, I think, in any business. Is that.
Given how many pitches you hear, are there areas, maybe one or two areas, where you do have a problem that you need to solve or you think should be solved, but you have not yet seen people focus on it or pay attention to it in a way that you hope would happen in the next few years?
So what's a missing?
Call to arms for entrepreneurs. If there's a white space where you see opportunity that no one else is pursuing.
I would say these areas where hybrid is important, where there are a lot of solutions that are exclusively digital, and on the PE side, ones that are exclusively physical for the most part. It's a roll-up or some sort of ambulatory joint venture. I think finding that space in between, because the future of healthcare is going to have both components. So if you're dealing with a customer problem, you're going to need to do it where you can deal effectively, digitally, in that environment, but then you can pass it off. A good example would be personal wellness. So a number of products out there, Oura Ring and Whoop and all that. Great stuff, great data. I've tried it, but okay, I've got all this data. It tells me I have a problem. Well, my objective is to solve the problem. Well, now I'm on my own on the physical side. What are those that can create a partnership that bridges that gap? So you've got the whole solution there. And I think that's what I'm looking for.
That is actually my number one criteria always, as well, as how do you connect into the broader ecosystem? Or at least have a theory of it, when you're first getting started. Amazing. My last question for you, Pete, is just given how much is happening right now in the broader macro healthcare landscape, much of which is very consequential to health systems in particular, whether it be on the regulation side, whether it be on the reimbursement side, whether it just be on the consumer behavior dynamic change side. How do you stay abreast of everything, and what are the signals that you do pay attention to versus not? For as advice for all of us who are dealing with a lot of noise and
there's
trying
a
to
lot
figure
of
out what the
noise,
signal
right? There's a lot of noise. Well, I listen to your podcast, But I do a lot of listening to podcasts of creators, innovators in the space, so I'm up to speed on that. I think the other thing is going around and meeting and really a network of in-person where you can have a candid conversation about what are some of the trends. Also, I think is expanding the time horizon on the trend. We want to be we don't want to be zigging and zagging based upon maybe a 1 year or 2 year thing. So, for example, I'll give you an example. I monitor what's going on in Washington, but you know what? It almost doesn't matter what the label is. The core macro conclusion is because of the debt as a percentage of GDP, we're going to get paid a whole lot less over the next 5 to 10 years, and we've got to make the adjustments in our cost structure. That would be an example.
Yep.
And similarly, around customer, the fundamentals of don't be arrogant to think you know what the customer wants. Really do the research and understand what they want. But realizing the macro trend of more consumerism is a constant, and the expectation that our customers and patients want to be more engaged in their healthcare, not only their healthcare, it's a whole area of being able to manage their family's healthcare. That's a constant trend that's always going to be there. So sorting the interim fluctuation with what are some fundamental constant trends that you're locked into that you're trying to stay aligned with.
Yeah. Amazing.
So, yeah.
Well, Baylor Scott White is very lucky to have you. Thank you so much for your time and for sharing all your insights with us.
Yeah, my pleasure. Thank you.